Does it sometimes make sense to allow the last primary teeth to exfoliate? Now, this patient is absolutely biting in a crowded position. There's no doubt about that. And we know that whenever the teeth are crowded, there's a higher likelihood that there could be chipping or wear on the teeth. Well, the overjet on this central incisor just got a lot better because all we're doing is retracting that tooth as we develop the arch. Now, realistically, if we wanted to have this ClinCheck be even more consistent, we could have placed attachments on the central incisors as well. So this is our patient when she first presents to our practice. At this point, she's 11 years old. Now, there's a few different things going on from a dental perspective. Notice, first of all, we actually don't have a ceph because we don't actually start treatment right away. So you see the ceph actually comes later. So ignore the cephalometric side of things, but just looking at tooth positions, what do we see? Well, we first and foremost see that she has a lower spacer. But what so frequently happens with a lower spacer is, even with the spacer, either the teeth had shifted first, or that's probably what really happened here, or it could be that something has adjusted or moved after the spacer went in. I do find that even with the spacer, the second molars can drift, or the first molars, I guess in this case, can drift forward and start closing some space. Now, because of how this was fabricated, I don't think that the situation is that this patient had shifting and movement happen while the spacer was on. Instead, I think we lost space, then the spacer went on, which prevented more loss of space, but this is the orientation of these teeth. And so in terms of our lower left first molar, we're going to have to derotate that tooth fairly significantly. Our lower right first molar needs to have derotation, but it's not going to be as much as what you see. Now, in terms of the maxillary arch, we've got a number of teeth that are falling out right now. And what makes this relevant in terms of making a decision is, do we jump in right now with treatment? Or when you have a situation where a lot of teeth are falling out, does it sometimes make sense to allow the last primary teeth to exfoliate? Now, this patient is absolutely biting in a crowded position. There's no doubt about that. And we know that whenever the teeth are crowded, there's a higher likelihood that there could be chipping or wear on the teeth. And let's actually even jump ahead to see the future. You can actually see it directly on this lower left central incisor. All of those mamelons have been worn off. So if we had started earlier, we could have prevented more of the wear. Now, why is it the lower left central incisor that has the wear? Well, it's because the upper left central incisor is the most lingually positioned tooth. So whatever tooth hits first is going to have more wear. You'd also think maybe the upper right lateral incisor, but it doesn't look like there's been as much wear happening on the lowers in that photo. But that lower central incisor is the most buccally oriented along with its neighbor here, the other central incisor, but this central on the upper is much further proclined, and so it's the most lingual tooth against the most on the upper with the most buccal tooth on the lower. And so we could have helped prevent that. But the reality is that because so many teeth were falling out at this time point, it's really challenging to get Invisalign trays or braces for that matter on the teeth, because if we bond to any of these teeth, well, they're about to fall out. We, of course, can't really bond brackets and wires to primary teeth at the best of times as well. And so the best situation here is actually to give this some time, in my opinion. Let the canines finish coming in more. Let these first premolars to come in. And if we have those teeth and we only are hanging on to our lower second primary molars, then we should be okay to start, even if we haven't lost those teeth. Now, this tooth here is going to end up blocked out to some degree. But in reality here, we took off the space maintainer, and you can actually see that the tooth erupting did actually push back this first molar a decent amount. So even if you are sometimes just making a move like taking off a spacer at the right time, you can see that there can be some self-correction that can occur. So this is actually great, because this is where we're going to start. So let's go ahead and jump forward to the future when we've let more teeth fall out. New ones have come in. We can see that there's some issues with demineralization on the first molars, and hygiene is obviously not good. So the first thing that we need to recognize for a patient like this is that they need to get better with their hygiene. If we don't improve hygiene here, it's not realistic that growing patients are going to get recession on teeth, but it's going to be a significant problem in terms of demineralization. So when I'm talking to these patients, I will normally be telling them and the parents realistically that if your gums stay like this, I feel like the cavity conversation doesn't get as much traction. Whereas if I say, look, if we do treatment on you, you're going to have your gums shrink potentially, which means that we're going to have to cut some of the gums from the roof of your mouth and then stitch it over top. That's why I need you to be so good with your brushing. If we just say that, well, we need you to be good with your brushing because your teeth are going to be gross, they're going to smell, you could get little white spots on them, you could even get cavities that are all brown. I find that patients don't care enough about that, and parents don't seem to care enough. So I care a lot more about talking about the gum recession, even though I know it realistically won't happen, because that seems to actually get some traction from our patients. So hygiene's poor, definitely needs significant improvements here. When we look at the biting position here, this patient is biting class 2 with their canines. On this side, doesn't look quite as class 2, but we'll see it on the ClinCheck in just a moment. And honestly, the ClinCheck is always going to give us the most accurate representation of what's actually going on. Okay, I'm going to go ahead and pull up the ClinCheck. So I'm actually going to start by toggling off the attachments, because my recommendation to you whenever you're looking at a ClinCheck is evaluate your ClinCheck with no attachments on, to just look at the position of the teeth. Don't put the attachments on because they're going to distract you. And even the staging on the bottom here, don't look at any of this staging right now. Instead, just look at the initial and look at the final. So what do we have going on? Well, this patient's biting in class 2. On the other side, they're also biting in class 2. We've got a significant amount of rotation on those lower premolar and first molars on our upper. Obviously significant overjet and quite a bit of crowding. Okay. So in terms of reviewing this ClinCheck then, I'm actually not going to go through in the same way that I often do for these reviews, where I go line by line by line, but I'm going to look more at the big picture things now that we've actually looked from our initial to our final. So I'm not saying that I'm doing it this way because I think you should absolutely replicate this exact same method, but what I want to do is I want to simplify some concepts for you here, where I go through my checklist quite often in these Invisalign demystifieds, but I want you to see too that you can just use common sense to look at these and evaluate some basic principles. You don't need to have the entire checklist memorized of how to evaluate the cases. So let's go ahead and take a look to start with. Here's my question to you. Is this a growing patient? Yes, it is. If we were to look at this patient's C-spine and evaluate their C2, C3, and C4, would we see immature cervical spine? Yes, we do. We can see that there has not been a curvature yet. We've not gotten full elongation of the C-spine. And so this patient still has growth, which is great. When this photo is being, this cephalometric is being taken, this patient's about 12 and a half years old. So let me go ahead here and then ask you, is this realistic that this patient could end in class 1 if we use growth modification? So if we're using elastics, if we're using mandibular advancement feature, if we're using theoretically headgear or a Mara or a Herbst or any class 2 functional appliance, can we modify this patient's growth to slow down their maxillary growth and allow the mandible to catch up? And the answer to that is absolutely we can. We absolutely can do that because that's what the cephalometrics show us, is that the C-spine is not finished developing yet. And so we know that this patient hasn't hit peak growth. So if we use simple rubber bands or if we use the wings on the trays to help posture the jaw forward, there's really no reason that we should set our goals and expectations on this case to be anything less than ideal. We have a saying in orthodontics, which is you treat growing patients idealistically, you treat adult patients realistically. Sometimes there's going to be an adult where you can't change the overjet situation. It's just not really doable because they've stopped growing. So you have a 5 millimeter overjet, you can't fix that. Right? They're done with growth. So unless you extract teeth and then pull the anteriors back, or whether you use a Carrier motion to pull the teeth back, or you use TADS and some other device, the reality is that sequential distalization, Carrier, extraction, those are all just retraction mechanics pulling things back. But to truly modify growth, the patient must be growing. So because of that, when we look here and we say, are they growing? Again, it's not rocket science. You don't need to be really well versed in all of this. You can simply say, are they growing? Yes. Therefore, well, if they're growing, then we can set our goals to be ideal. So at the end of treatment, if we just go ahead and we click to the very, very end, is this patient biting in class 1? Right? Has it simulated the adjustment of their position from their initial class 2 to a final class 1? Yeah, it looks pretty good. That's where we want this to be. And one of the things we can do is we can click on the staging tab on the top, this button right here, and we can click on this bite correction visualization. Now, my recommendation is that you always have this selected so that it shows at the end of active treatment. Because what that means then with your slider is, as you click and slide through the plan, so click and drag, 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 the very last step right here, which if we hover it, no, it's not going to tell us here, but often if you hover it, it will tell you that's the bite jump. So that's simulating a forward-backwards change, a jump of the lower jaw. What it's really simulating is it's slowing down the maxillary growth and allowing as much mandibular movement and growth as possible. And if we were to go ahead and use the grid tool here, we can actually count to see how many grid lines does the mandible jump forward. So from our first position to our final position right here, so let's line up our first molar there, and then let's toggle this forward to see the jump. And so we see that this jumps about 1 box is 1 millimeter, so that's like 1 millimeter and a little bit. 1.2, let's call it. So is it realistic that we can modify this patient's growth by 1.2 millimeters? Absolutely. I think that's totally reasonable. On the other side, so this is all tooth movement, and then at the very end, this is going to be the jump forward. So interestingly, when we actually look on the patient's left, they're jumping forward a full 2 millimeters here. 2. So they need twice as much growth correction on their left side as they do on their right side. Now, this is what's so nice about ClinChecks, is that you can see things that you would never see with braces, right? We can click on this, evaluate it, and see, yeah, even though you look here and say, well, what side looks like it's more class 1 or more class 2? I would say this left side molar looks to be in more of a class 1 position. But in reality, it actually needs more correction than the right side. And so because of that, if one side needs to jump forward more than the other, it means that the elastics we wear, well, we might want to wear the right side just at nighttime, and the left side we're going to wear it full time. Or maybe we want to use a heavier elastic on the left side and a lighter elastic on the right side. So that's what we're evaluating here just by checking that final bite position. So yes, we do want to correct them to class 1, and yes, we do want that bite jump, and yes, that bite jump is realistic. Let's go back to our plan 1 and just compare to see, did all that happen like we just described here? Because sometimes the ClinCheck will show that nicely and sometimes it doesn't. So what you'll notice first of all is you can see this kind of hashed grid line on the bottom. That's indicating here that the bite changes are happening continuously. If we click back to our plan 3, you'll see that it's not showing that grid line. But then when we click on plan 1, it does. So the difference between these when you see that is that, well, plan number 3 is showing that bite jump at the end of treatment, whereas plan 1 is actually showing that bite jump throughout treatment. But we don't want to see throughout treatment. We want to see what's the difference going to be if this patient wears their elastics or not. Right? This is showing a continuous change, so it's slowly sliding forward. But I don't want that. I want to click on here and go bite jump at the end of active treatment. So here we go, and jump. So that allows us to evaluate more accurately as to what's happening. But even in that initial setup, I did have them correcting to class 1. So that's good. Everything is finishing then in that ideal position. Now, what would be really nice is, let's say, as a quick aside, that you saw this bite jump and you toggled through it to get to the very end, and all of a sudden you saw the bite jump, and it was like 10 millimeters. Patient has micrognathia, and they jump forward 10 millimeters. Is that realistic in a growing patient? I mean, if they're a 13-year-old girl, probably not so much. If they're an 8-year-old boy, well, then we can modify a lot more growth. So depending on gender, depending on ethnicity, depending on age, we may have more ability to modify growth or we might not. And so if that was the situation, then we would not want to see a 10 millimeter jump forward on this, let's call it like 14-year-old girl. And of course, on a growing adult patient, we don't want to see any of it. And so realistically, an adult patient, we shouldn't be seeing a significant bite jump really at all. The only exception to that is if there's TMD issues going on, then we might. And in these growing patients, we could realistically see maybe 4 millimeters. So that's what we're calculating here by using the grid tool, is how much of a bite jump is occurring. And unfortunately, no other tool tells us that information, because if we go to our tables and we go to our overjet and overbite analysis, this is great, don't get me wrong. But the problem with this is that it's only measuring at the anterior. So it's measuring at the central and lateral incisors. But if you look, once we go ahead and start derotating the anterior teeth, well, the overjet on this central incisor just got a lot better, because all we're doing is retracting that tooth as we develop the arch. So that tooth's overjet, if you actually go into the tables and compare, it started off initially at 4.8 for our overjet. At the end of treatment here, it's 2.9. So it's saying here that you've reduced the overjet by 1.9, but that's only from tooth movements. This is not actually showing from the bite jump itself. So the bite jump really has to be measured to get an accurate reading of what the changes are. It needs to happen, because the tables don't show you anywhere, it needs to happen at the molar region. And the only way that you can actually objectively verify what that number is by clicking on the grid tool and then toggling what that simulated jump. Unfortunately, again, there's no other table here that will give you that information. The Bolton doesn't tell you, the arch width table doesn't tell you, the space analysis, the overjet and overbite doesn't tell you. You could click on the tooth movement table, and if you were to go ahead and look at, this is getting really into the weeds, but if you were looking at the translation in the mesial distal orientation, so we could click in here and we could hide everything except for our mesial distal translation. Then you theoretically could click on the lower table, and if you were to go ahead and click in the tools, sorry, you'd have to go into preferences and then click bite correction, not included in tooth measurements. You could click on include and then click on not include, and it will give you a different number, and that'll actually show you what the bite jump is on any tooth. But that's really a lot. So usually I leave it as the default of no bite correction. So anyways, that's the bite correction. We've gone through that pretty extensively now. Okay, so what are things that we're going to have to use in order to correct the bite? Again, I'm going in this intentionally in a different order than I often do, because I don't want to just tell you follow this checklist. Right now, I want you to stop, drop, and think. I want you to understand what we're looking to do rather than just telling you what to do. So when we look and evaluate, let's go ahead and first look at the attachments. So what do we need to have in order for us to modify the growth? Well, we have to have elastics. So this is our old plan. This is plan number 1. So we'd placed elastics on the buccal of the lower first molars to the canine of the upper canines. So buccal of lower first molar to upper canines. And that's fine. That would help with the correction. If you were theoretically to place a button on this tooth right now, and how I like thinking of elastics and how they work. So here's our button. You know what? Let's make it blue. Make it pop more. Okay, there's our button. And let's say you grabbed an elastic rubber band and you hooked it onto this button. And don't even think about it going to the upper arch or anything like that. You just hook this elastic on, and then now you're using your fingers. And with your fingers, you're grabbing it right here and right here. My beautifully drawn fingers. Okay, you're pulling that elastic back. So which direction is this elastic moving? I'm pulling against the tooth. Well, obviously the direction of the elastic. And so what that's going to do is it's actually going to pull that tooth forward and it's going to spin that tooth around its long axis. Right? So this tooth will be spun slightly so that the mesial buccal gets pulled more than any other area on the tooth. It's going to be pulled forward. And so that's not actually going to help benefit the positioning of the tooth in terms of its rotation. But now imagine we did this. Imagine we put the button cutout right here. We put it on the lingual side. And I guess I'll use blue since that's what I was using before. And now what we're going to do is we're going to go ahead and hook on with our elastic. There's our elastics hooked on, and we're pulling. Again, we're pulling right here in this direction. Well, what's going to happen? Well, the mesial aspect of this is going to get pulled anteriorly. So because of the derotation, it makes more sense from a biomechanical perspective to place the button on the lingual mesial side, or it could even be on the distal lingual side. So that would also be fine. We can put our button anywhere, kind of in here. Get the right color here. Sure, we'll use gray. We could place it here, we could place it here, we could place it here. Anywhere here is going to help rotate that tooth towards the mesial. And so because of that benefit, that's why we change the location. We say, hey, let's go ahead and put our button on the lingual side because that will help spin the tooth. We may as well use the elastics to our advantage, and that'll make things much more consistent. Now it's a little tricky here. I'll go ahead in some photos because this isn't the initial positioning, but you can see that here is where we actually have a button on the tooth. So we place it on the lingual side on both the lower first molars because we're able to effectively spin this tooth from its initial position here to its position partway through treatment, like you see in this photo here. Now, we also don't necessarily use a button on the tooth because buttons are pretty uncomfortable when they're on the lingual for the lowers. And so instead what we're actually using, which let me see if the other photos show it better. Fortunately, that tongue is usually in the way. But we're actually using what's called a Kaplan hook. And the benefit of a Kaplan hook is that it's very low profile. And so the Kaplan hook allows you to have a little loop. So this little loop right here is where the elastic can actually hook underneath of. So it's much more forgiving. It's not like a post that's sticking out and hitting up against the lower lingual soft tissue. Instead, it sits down. It looks like it's pushing into the tissue here, but it's really not too bad. It's fairly smooth and comfortable. So that's the Kaplan hook. So let's go ahead and look at the actual ClinCheck because I think that shows sometimes in a nicer way what it actually looks like. So let's go, and I'll show you on the side here. So here's treatment plan number 3. So this is what we planned for with our derotation of that second molar. And then here's what we actually accomplished. Now, if we look at our lower second premolar, what's actually quite interesting is that oftentimes doctors will say, well, Stephen, you change out a lot of attachments. You place things on the lingual, or you've changed and optimized for unconventional attachment. But in this scenario here, the main movement that we need to do is rotation. Right, we have a lot of rotation happening. If we were to actually go ahead and look at our tooth movement table here, there's a much easier way of doing this, but it would require me to be in the ClinCheck. But I'm just going to go ahead and look at rotation and root tip, also known as angulation. And if we look to our lower, let's actually check this out. I'm curious to see. I don't pre-look at these cases, as an aside. I'm only going to get movements that are more than 5 degrees to show up. So I don't pre-look at these, so I'm not biased by anything that I've previously done, because I want to look at it through a fresh lens. If we click on root movement here, and we're looking essentially at the 3, 5. So there's 53 degrees of rotation, a metric ton of rotation. In terms of the angulation, the root apex movement, there's almost none. It's less than half a degree. So it's nothing. So this is the biggest movement. And so the attachment that we have on this is an optimized rotation attachment. Now you could have changed this out for a vertical attachment with no bevel, or a vertical attachment with a bevel. You certainly could have made those changes. But the reality is here is I want to show you that when there's only one order of movement, it's actually very consistent for us to derotate this tooth. Well, I shouldn't say it's very consistent, but it definitely can be done because there's no root tip, because there's no significant root torque, because there's no significant extrusion. All that we need to do with this tooth is rotation. And so as long as this patient wears their trays effectively, we absolutely could get the derotation just from utilizing an optimized attachment. The downside would be is that if this tooth did not fully rotate, this current attachment on the tooth then is not effective enough that we could leave it in place. Because these optimized attachments are designed to be taken off every single series of aligners unless you finished the movement. So in this case here, we've pretty much finished the derotation right in our first series. And so we did not plan to remove the attachment and place new ones because that's clinically inefficient. But that's the movement that we're essentially looking at on this lower premolar. Right? It was just a significant amount of rotation, and that's why the rotation attachment was very effective. But if we had the rotation and root tip, or we had the rotation and extrusion, if we had any secondary movement on it, then I would recommend likely changing out that attachment for something else. Okay? So we've essentially looked at our molar positions, and we've looked at our rotational movements. And actually, let's look at the other side to see, did we have a similar setup? We didn't, because we didn't really need to rotate that tooth any significant degree. Okay, what's coming next? Well, when we come to our incisors, we know that lateral incisors are very tricky to move because geometrically they're really small teeth. Now hers fortunately aren't super small, but we do need to have a decent amount of expansion and proclination of those lateral incisors. Now realistically, if we wanted to have this ClinCheck be even more consistent, we could have placed attachments on the central incisors as well. If we go to our tooth movement tables and maybe go to our maxillary teeth and we look at our 1-1 and our 2-1, you see here that we have 7 degrees of rotation on both the central and 6.6 degrees of rotation on the other central incisor. But yet, we've not placed an attachment. Many of you who've taken attachments in biomechanics might say, hey, Stephen, should we not place a sash attachment on that central incisor? It's more than 5 degrees of rotation. And you wouldn't be wrong. You certainly could. But you can also use discretion to see who's the patient that's in your chair. Right? This patient coming to our practice is highly motivated. She's a really good kid. She needs motivation on her hygiene, but she's totally fine, in my opinion, when it comes to her motivation of doing the treatment. And so because of that, we gave more freedom with the attachment designs. We didn't need to throw the whole kitchen sink at her because I felt quite confident that she's going to actually wear her aligners. And because of that, then we're going to give a bit more freedom in terms of the attachments and lack thereof that she has. So that's what we have going on with her centrals. Now, let's go ahead and take a look so I can show you what actually happened. So here's her centrals. And then that's a progress. So here's where she's at the end of her first series of trays. Right? Great derotation. There's no root tip required on those centrals or on the laterals for that matter. And so the proclination, the derotation, those are all really straightforward. They're not super hard things to do. And so at the end of the first series, things look pretty good. Okay, so what's next? Well, let's look at our canines, because those teeth, well, really, if we look everywhere else in the mouth, there's nothing significant going on any other teeth other than our canines, because we don't have a significant deep bite. We don't need a significant amount of AP changes. So it's really the canines that are high. And so what we need to evaluate and look at then from our canine position is, well, how do we get those canines to come down? Now, let's go back to the photos again, because when you look at this canine here, it's erupted more, and there is a decent amount of space between the canine and the first premolar. The other thing I want you to pay attention with these canines is the height of contour of the tooth. Right? The widest part of the tooth for this tooth is going to be somewhere just under the gums. If you measure across a fully erupted tooth, that's about where it's going to be. It's not super far incisally. Like if you look at a central incisor, oftentimes the incisor is widest close to the incisal edge. But on canines, the canines are actually widest maybe I don't know, 5 millimeters down from the incisal edge. When we look to the other side, what you'll notice is there's a small amount of crowding. And while there is a bit of gum tissue between the canine and first premolar, the height of contour is much higher than the neighboring tooth. Why? The contralateral tooth, the other canine, right? When I look at this canine, I see space between that canine and the neighboring tooth. And I say, you know what? I think that this tooth is going to be pretty consistent in coming down. When I look at the other side, I go, this does not have as much space as the opposite side. And so I think there could be a scenario where this canine might have more difficulty coming down and extruding. So let's look at the ClinCheck. Right, we actually have that 1.9 millimeters of space, and we know that we're not too far in terms of the width of the tooth from it erupting enough that the height of contour, the widest part of the tooth, is down. Whereas on this side, the tooth is higher. It actually is interesting. I didn't realize it was 1.4. It's only 0.5 different, but there is less space available. And so what I would just do nowadays that makes this super predictable is I would not close up all of this space. Because look at what I do first. I actually start by closing up space. I move all the anterior teeth back before I extrude the tooth. I'm going to be completely honest with you guys. What a stupid thing I'm doing right now. I have space around the tooth, and yet what I'm going to start with is closing the space before I erupt the tooth. Why? Closing space between teeth is super, super easy to do. We can do that at any time. Extruding teeth is a lot more work. So why am I starting off by closing the space I have and then extruding? It's illogical, it doesn't make sense, and it's going to cause me problems later in treatment. And again, if you guys have ever heard me speak before, I'm here not just to give you the rainbows and sunshine, but to also show you the stupid things that I do. See if I'm an idiot on this side too. Now on this side too, I'm also doing that. But fortunately here, I would say it's a bit better because, well, that tooth's a bit more erupted. But realistically, if I was treating this all again, what I would do differently is I would not close that space. I would actually intentionally leave more space around that tooth. And let me just pull up, this is the sister's ClinCheck that's completely done by this point. But let me pull up the sister's ClinCheck so that I can just do a modification because that one's set up as a test case. And then I will show you what it actually looks like to create space around that tooth. Because if I did it all again, and this is what I do so frequently now, is I create extra space around the tooth and I bring that tooth down and I don't even close that space. So if I was going in here and clicking modify plan and I needed to bring down a canine, I'd simply click on this, the arrows that are above the tooth, and I'd say add spacing, and I'd go usually 0.5 millimeter. Mesial and distal is the sweet spot. Because once that tooth is down, then in a new ClinCheck, we can simply close the spacing around that canine tooth. Right? Rather than ending with this perfect, finish with spaces around it, and then that's going to make your life much easier and more consistent. And I don't do that here, and I get away with it on one side, but on the other side, it's going to burn me. Because here's where we're at after the end of our first series. So we saw the premolar derotate, we saw the first molar rotate. We can see the class 2 correction that's occurred, which is great. Same thing on this side. We're biting pretty much in a class 1 now. Now this side is not perfect, but it's better. And so what I'm evaluating and looking at now is saying, well, I need to get these canines down. How am I going to do it? Well, that's the debate now, right? How do you bring down those canines? If we continually just try to pull that tooth down, what's going to end up happening is, if there's not enough space for the tooth to come down, think of it this way. The lateral incisor and the premolar are kind of like the two brothers. And they're squishing their little brother between them. You can kind of think of it like there's two brothers here. They're both squeezing their brother between them and then lifting them off the ground. And so this tooth, this canine, even though it's the big tooth, it's kind of like its feet are dangling up in the air and it can't reach. And so that's happened on both sides here. So we need to get those canines down, but how we're going to do it here again is not the right way. This is the way that is kind of a default, which is, again, remember, where's the widest part of this tooth? Right now it's underneath the gum surface. And so let me go ahead and show that on the actual plan. Instead of creating space around the tooth, all we're planning to do here is to, well, hey, let's hook on our button, and we've got elastics on the bottom here, and we're going to try and run the vertical elastic to pull that tooth down without creating any space around that tooth. And so what ends up happening then is, well, kind of what you'd expect. When you come back and look at it at refinement, nothing has changed. Nothing has improved. The tooth has not extruded. Now on the other side, let's go and look at this one from before. This one does come down a bit more because the tooth is further erupted. The height of contour is a little bit lower, but the other thing that you'll notice is, look at how when this tooth extrudes, there is a bit of space, and we don't close that space right away. It closes more, well, it doesn't really actually ever close. This probably should show like a 0.1 millimeter of space, but this actually happens. Right? When you compare, this is the previous ClinCheck. Let me just show you the ClinChecks on the side so you can see. So from here to here, it gets more socked in, but on the other side, nothing changes. So what do I look at here? I go, wow, I guess my lower canine isn't extruding enough. I need to use a button on this, or an attachment, sorry, to try to extrude this one more as well. And then here, well, why don't I jump in here with an IPR burr? Why don't I try and IPR between these teeth to create space? But the problem is, again, this is completely illogical. It's irrational. It does not make sense. And I'm not here to show you all the things that go well. I'm here to show the stupid things that we do so that you don't have to make that same mistake. Because what we're doing is, by taking the IPR burr and doing IPR between the teeth, great, we did the IPR. But what does the ClinCheck show? Well, the ClinCheck shows as soon as we create that space, forces those teeth back together again. And so the space that you just created is completely gone because of the movement on the actual plan. So we start off, here comes our IPR. Okay, there's the IPR. And then now, as soon as we would have theoretically created space with IPR, the trays push the teeth together, closing the space we created. If we wanted to be successful with this plan, what we should actually do is not plan IPR in, and instead just do IPR. If you were to just do IPR, but you didn't plan it, then the trays won't close the space. They won't try to remove the space, and it would allow you to extrude your tooth more effectively. But instead, well, we didn't do that. And so at this time too, we've also taken off, I guess we still are running the class 2 elastic slightly from the lingual side here, so that's what we can do to try to pull that down a bit, but the vertical elastic we had before is still more effective. But this is still just not biomechanically the most sound way of trying to bring these teeth together. And yes, the lower canine is sitting lower than it should, so placing an optimized extrusion attachment on this tooth is fine. Same thing with the lateral incisor, to both extrude it and work on a bit of root tip. That's totally fine. But we're missing the point here of this canine tooth. So that's where we're at with our theoretical position. And then you can see here, well, what we actually did in the real world is I recognized that this tooth wasn't coming down, so we did a small amount of IPR between the canine and the lateral incisor that wasn't actually planned to be done. By doing that small amount of IPR, that allows the canine to come further down because we created that space. But again, no IPR was needed to be done in that area. We could have simply just let that canine come down and not plan the IPR. And if we had space around it, it probably would have worked fine. But instead, we had to go through all these extra steps in order to make this happen. And so then what we're going to do is we're just simply going to close the spaces between these teeth. So we close that space, and then we're pretty much ready to be done. The other side, not a lot of movements needed because we got that tooth down earlier. So again, just simply closing some of those spaces. So let's go back to our actual photos. So you see this was the initial time point at which we tried to pull down that canine. Didn't make sense. Then we get to this point here. Still, that tooth has not come down. Still, the tooth has not come down. And then finally with some IPR, once we create more space around the tooth. So again, this is IPR that was done, that was not in the plan. There was no IPR in the plan. Now we can go ahead and close that space. And even then, again, You can see that we don't have the nicest closure of the canine and premolars. We can let things settle a little bit more over time. So that's what we do. With our temporary trays, we let things settle. And then the last thing here that I want you just to see, which is interesting about our plans, is let's go back one, because this is where we're at with our progress. Is you can see that sometimes the molars haven't finished erupting. So even though everything's straight, it's all in proper alignment, the first molars aren't in. Second molars aren't in. And so what we can do is we can simply get some more trays for this patient. Now, this is a really old case, so we could get more trays back in the day. But if you look here, you can see that, well, all we're going to do is close up some of those spaces between the teeth. And then we're just waiting, because we have the eruption compensation in the trays, the distal bite tabs, to catch the erupting teeth that are coming into the mouth, right? Because the second molars aren't in yet. So our lower right second molars partially in, our lower left second molar is not in, our uppers, neither of these are in. And so we give the patient essentially trays without any attachments, without any buttons, without any elastics. And they just wear them at nighttime. So that gives us time to allow the teeth to start erupting. So then over the next period of time, teeth erupt little by little by little until at this point, which we actually can't see our second molars the best, but maybe you could say here. At this point now, because we have eruption of those teeth, we can now go ahead and finish up the treatment because those teeth have fully erupted. The classic problem with braces is that braces, well, you need to go into your final retainer sooner. And it's tricky to say because of the angulation of how these teeth came in and the photos don't show it the best, but maybe we should actually do a bit more movement on those second molars here, which we certainly could do, even just at nighttime, to ensure that everything is dialed in as properly as we can. But it actually does look quite good in the photos here that the teeth have nice cusp-fossa relationships. But the gist of this is that we've been able to create the ideal overjet with the ideal overbite, with the canines coming down, with the molars coming in, with all the corrections, so that this is our patient's final position compared to our patient in their initial position. Now, granted, she started treatment at this point here, but we absolutely can make these changes for our patients. Essentially, this patient had let me go back so you guys can see. We had one batch. If I'd been smarter, we would have probably been done after 2 batches, but I wasn't. So then we had 3 batches, and then we had 2 batches while we're waiting for these teeth to come in. So essentially, we had 3 batches of active trays, and then we have 2 batches which were just done to help hold things over while we waited for more teeth to come in. So that's essentially the treatment time length. If we're looking at the actual treatment, treatment in the daytime, we were at the point of being completed with this case. It took us, I'm just looking right now, it took us just under 24 months. So the reality is that doing things to this standard takes time. I could have certainly been done this, in my opinion, probably closer to 18 months if I was better in how I set up my ClinCheck, but I wasn't, and so unfortunately that meant more treatment time. But that's the thing of orthodontics, is we have time. Even if you make mistakes, this probably would have taken me 2 years with braces. And it would have been a pain in the butt to try to derotate that lower second molar, first molar. And so realistically speaking, we should be telling these growing patients that it's going to take time for us to get the results that we need. In terms of the reason why I do this, I think many of you know already, but it's because I love teaching general dentists how to treat to a higher standard. We absolutely can be doing complex cases, and we can be doing them really well. We have our clearly aligned and clearly select opportunities for doctors. Clearly Aligned is the education company that covers all the education, whether it's this free stuff, whether it's courses that are in person like I'm doing currently while you're watching this in Sydney as I'm lecturing on foundational systems. I think we have about 55 doctors who are signed up for that, or just whatever it is. It's the baseline education is through our clearly aligned community. When it comes to if you want to take your practice to the next level and receive more support, receive discounts with your Invisalign cases, receive the business insights into how we approach things, get access to every single one of our online courses, get support with 10 ClinChecks So ideally with those 10 ClinChecks alone, you're going to be doing an extra 10 cases that were normally outside your comfort zone, but with us supporting you and helping make you feel comfortable in the plans, which means if you're billing even $5,000 per case, you should be billing an extra $50,000 per year. Doctors in our community save over $110,000, or sorry, make an extra $110,000 in their first year just from doing extra cases because we're giving them the support. And so that's my goal, is to change the landscape of orthodontics in terms of how we do it as general dentists, to do it to a higher standard, but also to make it very profitable and enjoyable. Because the amazing thing is that even though right now for you guys, you're watching this lecture, for me, I'm lecturing in Sydney at the same time, my practice is also still running. So our staff started a number of cases today with me being across the world because I don't physically have to be in person to be doing all these things. That's the awesome part of it, is that as you scale and you grow and you get your team more involved, it's the only area of dentistry where you physically don't have to be doing something in the patient's mouth to be making money, other than, of course, the business side of just owning the business. But it's way different than placing implants, because you can only work as fast as your hands can place them. And so with orthodontics, you don't have that same limitation.